Tonight, I'm going to focus on discussing the use of focused ultrasound for the treatment of essential tremor specifically. Marsha gave me, just introduced me, but I wanted to let you know a little bit more about me. I grew up here in Orlando, Florida, just a couple hours south of Gainesville. And I did my undergraduate training at Duke University, majoring in biomedical engineering, and then transitioned to the University of Virginia for medical school. And then I completed my neurosurgical training here at the University of Florida several years ago. And then I've been on faculty here at UF for many years. My practice is primarily focused on the treatment of essential tremor and Parkinson's disease, and using both deep brain stimulation and focused ultrasound to do so. And we'll touch on both of those procedures tonight. Here, an overview of the agenda. I'm going to talk about what essential tremor is, what's going on in the brain to cause it, and then I'll provide an overview of focused ultrasound technology. I'll review treatment day logistics. We'll discuss benefits and the risks of focused ultrasound. I'll describe who is a suitable candidate to receive focused ultrasound. And I'll compare and contrast focused ultrasound to DBS, or deep brain stimulation. And then we'll open up to a question and answer session. So let's get started here and talk a little bit about essential tremor. Essential tremor goes by many different names. It can be called a familial tremor, idiopathic tremor, or intention tremor, or benign essential tremor, sometimes it will be called. And the tremor typically occurs with movement of the arms and is less commonly present at rest. So an essential tremor is distinct from a resting tremor that is commonly associated with Parkinson's disease. A resting tremor, just like it sounds, present at rest. An essential tremor, present with movement. So oftentimes you won't have any tremor when you're just sitting there, but then you go to reach for a pen or a cup or a sandwich, and the patient would experience tremor in that state of motion.
Dr. Hilliard, can I interrupt and ask you to speak up just a little bit louder? I'm getting some messages that it's a little hard to hear you, or maybe move just a little bit closer.
Oh, sure. Apologies for that. Is this better?
That is better, yes.
Okay. So essential tremor, I'll just review this slide again. Essential tremor is a movement disorder that occurs with movement. It occurs as you're moving your arm around to try to perform an action, as opposed to a resting tremor that's present when you're not moving. Resting tremors are typically associated with a movement disorder like Parkinson's disease, whereas tremor associated with motion or when in motion is typically associated with essential tremor. That being said, as essential tremor progresses, as people have it over time, it can get so bad that not only do you have the tremor when you're moving, but you also have it at rest. Patients with essential tremor may also have a head tremor or a vocal tremor that is evident. And it turns out that tremor is pretty common, about 1% prevalence in the general population, and it affects 1 in 20 people over the age of 60. Tends to be a genetic link. About 50% of patients who have had a loved one, someone they're related to, parent, grandparent, an aunt, uncle, sibling, who has tremor. And thankfully, there's a substantial medical regimen that can be embarked upon prior to the procedures that we're talking about that can have result in a significant improvement in tremor. So common medications to treat essential tremor include propranolol, primidone, topiramate, and gabapentin. And about half of patients respond well to those medications. But over time, the tremor tends to progress and the medications lose their efficacy, and or patients develop side effects from the medications and have to stop the medication. So what causes essential tremor? When we have a thought to move, to pick up the pen, to pick up a cup, and so forth, our brain creates a plan of how our arm is going to move through space. But as soon as we begin to move, our arm has a slight deviation from the planned movement. This is common. It rarely rises to the level of consciousness. Our brain, a portion of it called the cerebellum, is responsible for detecting deviations from planned movement. And it sends a corrective signal to a different region of the brain called the thalamus, which you can think of as a motor relay in the brain. And that corrective signal, the thalamus receives it and keeps us moving in a controlled manner, in a very precise manner. In someone with essential tremor, the signal that should be corrective from the cerebellum to the thalamus has some noise associated with it. And that noise is interpreted by the thalamus as a signal to oscillate back and forth. And that is what we describe as tremor. Focused ultrasound uses ultrasound energy to create an ablation. It destroys a small region of the brain along the tremor pathway, connecting the cerebellum to the thalamus. And in so doing, by disrupting the tremor circuit, it helps to significantly alleviate the tremor that a patient is experiencing. This is an example of a before and after of one of my patients. You can see on the left and the right. And this kind of result is fairly common, okay? Having a really bad tremor, and then when we're finished with the procedure, looking as it does on the right.
During the treatment, you will lay down on the treatment bed inside the MRI scanner. The medical team will be in the control room, and you will be conscious and able to communicate with them. Your head will be positioned in the focused ultrasound helmet, which is filled with water, and you will have a blanket to keep you warm. You will be given a stop sonication button if for any reason you want to stop the procedure. MR images are taken to plan the treatment. Your physician will first apply light doses of ultrasound energy to identify the right spot in your brain for treatment. Then, full intensity ultrasound energy will be applied. The treatment bed will move in and out of the MRI. After each application of ultrasound energy, you will be asked to do tasks such as drawing spirals. This is so the physician can evaluate the improvement of your tremor and any potential side effects.
That was kind of a cartoonish overview. I'm going to go through the treatment logistics here in detail. So the first part of the treatment really involves being evaluated. So meeting me in the office, reviewing your history, making sure that the tremor that you have is actually an essential tremor, ensuring that you've gone through appropriate medical management, that you've exhausted medical options. Focused ultrasound, it's a great therapy, but I don't want to do it. We don't want to do it unless we're treating it like a last resort. On the day that you meet with me, we will obtain a CT scan of your head and an MRI of your brain. And there are two different types of images that give me two separate pieces of information. When we're delivering ultrasound energy to the brain, it first has to get past your skull. And everyone's skull is a little bit different. Some of the ultrasound energy is going to be reflected off the skull. Some of the ultrasound energy will be absorbed by the skull, and some of the energy will pass through the skull to get to the brain. That's what we want to have happen. That's what we need to have happen. About 1 in 8 people will have a geometry of their skull such that even if I turn the machine to its limit, I can't deliver sufficient energy to the brain past the skull. So in other words, 1 in 8 people will have a skull geometry that will reflect or absorb so much energy that I can't get a sufficient amount to the brain to change, to cause the change that we need to impact your tremor. We take the CT scan and we run it through a simulation. And that simulation allows us to discern whether on the day of treatment we'll be able to get the amount of energy that we need to the target spot. So we get the CT scan, and then we get an MRI. The MRI takes a high quality picture of your brain and allows me to identify the location in the thalamus that we want to target, where that tremor signal is entering into. So by the conclusion of that day, we'll have all the information that we need to decide, hey, can we do this or not? And then should we decide to move forward? On the day of the procedure, I'll meet you in the pre-procedural area. And then I need to shave your head. Now, this is not my preference, but this is a universal necessity, whether you have the procedure done here or somewhere else. Hair, even a little bit of hair, can reflect the ultrasound waves in a manner that's unpredictable. And we need to be able to predict precisely where the ultrasound waves are headed as they enter through your skull to your brain. So I'll perform a complete head shave, and then I'll apply a small frame to the head. That frame is held in place with 4 little pins, 2 in the front, 2 in the back. Those pins would hurt if it weren't for some numbing medicine that I would give you first. Most of you have probably had numbing medicine in the past, and you know it stings pretty bad for a minute or two. You let it settle in, get nice and numb, and then apply the frame. The frame will feel like you're wearing a hat that's just a little bit too tight. Nothing terrible, just a little snug. We'll then head back to the room where we do the procedure. Even though it's called focused ultrasound, it's done in conjunction with an MRI machine. So just like this picture shows, you'll be within an MRI machine. The frame that I place on your head will connect to the table, which will keep your head absolutely still while we're delivering the energy. I'll pad up behind your neck and your shoulders and underneath your knees to make you comfortable. You'll be able to move your arms and your legs. And then the ultrasound cap will come down and connect to the head frame. You'll slide into the MRI machine and we'll get an image. I'll merge that image. That takes about 15 to 20 minutes to get that image. I'll merge that image to the high quality MRI that we obtained the day that you saw me in clinic that already has the plan on it. And then I'll begin to deliver small amounts of energy. Typically, it takes 4 to 8 doses of energy in order to reduce the tremor to the point that we desire it to be reduced. Each dose is a little bit more than the last dose of energy, so escalating doses until we're finished. And the last 1 to 2 doses, it's typical to feel a headache, numbness or tingling, or a spinning sensation, like you're kind of going head over the heels. It takes about 20 seconds to administer the energy for each dose. As soon as the dose is completed, sensations of headache, numbness, tingling, and spinning rapidly dissipate. 4 to 8 doses, 20 seconds each, escalating doses. Between doses of energy, I'm coming into the room, you're coming out of the machine, and I'm making assessments to see how your tremor has improved. And I'm doing that by assessing spirals, like I showed you a few slides ago, having you do finger to nose and kind of seeing how your hand and arm is working. Once satisfied with the tremor reduction that we have, we'll remove the head ring. You'll head to the recovery area, spend about 45 minutes there, and then you'll go home. The next morning, we get an MRI that shows us the evolution of what we've done. What do I mean by that? Well, we're going to target a 4 millimeter spot in your brain. That's along the tremor circuit that will be permanently impacted. It will be destroyed. The surrounding brain tissue is irritated that we did something to that 4 millimeter spot, and it will swell a little bit. And that swelling can create some temporary dysfunction in neighboring structures that control other aspects of us. I'll get into side effects in a few minutes, but I want to show you what this post-procedural MRI might look like. So this is from a study in 2014 that took an MRI of a patient 1 day, 1 week, 1 month, and 3 months after the procedure. And if you look closely here, you can see there's a little dot here. That's about a 4 millimeter spot. And that white that you see is a little bit of swelling. And you can see how it fades over the course of about 3 months. This picture below is a blown up version. And what's permanent is what's dark there that I'm circling right now, what we refer to as zone 1. Zone 2 and 3, which is this white and then this black rim, that's the swelling that I'm talking about. So you can see how it's several millimeters larger than what is permanently impacted. As that swelling dissipates over time, the side effects that I'll reference in a few minutes will dissipate. Here's a video of somebody before and after the procedure. You can kind of see the change in the tremor control. These are not my patients, but this is just some file footage I have from 2 real patients who did undergo focused ultrasound. What can you expect from the procedure? An immediate and durable tremor improvement. I'll take you through the numbers in just a minute, what that looks like. An outpatient procedure. You come in, you do the procedure. We're back in the MRI area for about 90 minutes or so. When we're done, recovery area for 45 minutes, and then you're going home. There's no incision. There's no risk of infection. There's no anesthesia, no general anesthesia, I should say. There's a minimal risk of hemorrhage or stroke. It's about a 1 in 500 risk of having a bleed in the brain or a stroke. There's no maintenance involved. There's no hardware, nothing being implanted inside of your body. There are no restrictions for future imaging. In terms of tremor improvement, I am taking this information from some of the most thorough studies that we have since the introduction of focused ultrasound. This one that I'm referencing here over on the left was a randomized trial of focused ultrasound for essential tremor, published in 2022, and it showed a 73% reduction in postural tremor out to 5 years. The study lasted 5 years. Postural tremor is a little bit different than intention tremor. Postural tremor is when you put your hands like this, and I'm mimicking what it might look like for somebody with essential tremor. A 73% improvement in that motion, durable out to 5 years. I think that this is the most important outcome measure, however. This slide demonstrates change in disability scores. So disability scores it's essentially a type of survey given to the patients or administered to the patients that is quantifying how disabled the person is by their tremor. And so it takes the person through a series of questions about eating, drinking, writing, clothing, hygiene, brushing your teeth, shaving, etc. And what it shows is a 67% improvement in disability out to a year. And it wanes to about a 45% improvement at 5 years. So over time, the effect of focused ultrasound wanes some. Really what it is it's the disease progressing, okay? So as most people who may be watching with essential tremor know, the tremor has gotten worse over time. And it will continue to get worse if it weren't for the focused ultrasound. So focused ultrasound, it's not a cure for essential tremor. It significantly reduces the amount of tremor that you have. We're destroying a portion of that tremor circuit, but not the whole thing. If we tried to destroy the whole thing, the risk of causing you a permanent side effect would be unacceptably high. So we're really aiming for about a 70 to 80% tremor reduction. That's what we can do safely. And this sounds a little odd with the way I'm about to say it, but 70 to 80% is not 100%. And I just reiterate, it's not a cure, but it's a substantial improvement. And as time goes on, the portion of the tremor pathway that remains, that noisy signal gets louder, if you will, and its effects can reach the thalamus, which accounts for what we see in this graph for the waning efficacy over time. Another question that I commonly get is, well, can you repeat the focused ultrasound? I'm going to give you as much energy as I think I can safely give you the day we do the procedure. to eliminate your tremor as much as possible. It would be foolish of me to think that 5 years later, I could give you more energy safely when I didn't think I could do so the first time through. There are rare exceptions to this, but essentially the answer is no, we can't redo it. It wouldn't be safe. Let's talk about side effects. Remember, I mentioned that there's swelling in the brain after we perform focused ultrasound. That swelling peaks about a week after the procedure, and then it dissipates over the course of 2 to 3 months. The most common side effects are speech, changes in speech, slurred speech or word finding difficulties that are mild, changes in balance and walking, feeling like you're leaning to one side or the other, or that you don't have just quite as good of power in one of your legs, or maybe you feel like your foot is dragging a little bit. Coordination, it's a clumsiness, meaning that your tremor's better in your hand, but if I were to hand you the pen, you would kind of fumble with it a little bit potentially. And numbness or tingling, sensory changes. Again, the peak swelling is within 2 to 5 days after the procedure, and then dissipating over the course of a couple months. Most people, after that first week, are telling me that, yeah, I noticed a little bit of change in my balance. Maybe I'm a little bit clumsy. My tremor's looking great. I can already tell that, my balance is getting better, or I had speech issues for the first few days, and now I'm getting better. That's the common experience. People who are affected for a longer period of time tend to have had poor reserve. And when I meet with you in clinic, I'm able to counsel you according to your specific circumstances. Obviously, in this webinar, I can't give everybody a specific, what do I think about you? So I'm giving generalities here. But most people, within about a week or two, they're feeling like they're over the worst of it, and they're well on their way of headed back to normal with nice tremor reduction. Focused ultrasound has become a very popular treatment method for essential tremor. It's the latest data that I have available in 2022 across the world, about 3,500 thalamotomies or procedures performed. And in the United States, focused ultrasound surpassed DBS as the most common intervention for essential tremor in 2021. So who is suitable for treatment? I mentioned a confirmed diagnosis of medication refractory essential tremor. So this is somebody who has failed medical treatment, who's been on medications like primidone or like propranolol, and either they weren't effective enough, or you couldn't be on a high enough dose because of side effects for it to have the impact that it was desired. Somebody who can tolerate laying flat within an MRI for about 90 minutes. Now, I'll clarify here that you're not in the center of the MRI machine for 90 minutes. There are portions of time where you are in the all the way in the machine in the MRI, but there are also substantial portions of time where you're out of the machine and I'm making assessments. I'm checking your tremor, we're chatting, seeing how you're feeling, and so forth. So for people who are worried about claustrophobia and so forth, if you can obtain the planning MRI that you get the day that you meet me, I have very little concern that you can complete the actual procedure, because on the day of the procedure, you go in for a little bit and then you're out. You go in and then you're out. And we're there to talk to you and explain what's going on. And frankly, most people, even those who are claustrophobic, they become so focused on the improvement that they're seeing in their tremor and so excited by that, that their concerns about being in the enclosed space are a non-issue. There are some people that we can't perform this on. So non-MRI compatible implants. Okay, that's like a cardiac pacemaker, an older cardiac pacemaker, for example. A skull density ratio out of range. So I mentioned skull geometry. This is the language. The skull density ratio is really the calculation that we're performing. And like I mentioned earlier, it's within the range of 1 in 10 to 1 in 8 people will be out of range, or we cannot deliver sufficient energy to ablate the target. But we'll know that once we get the CT scan on the day of the office evaluation. So what about deep brain stimulation? I do deep brain stimulation too. I love DBS. It's the reason that I went into neurosurgery. It's the reason I became a neurosurgeon. And we do a lot of DBS at the University of Florida. We do several hundred cases a year. DBS, in my mind, remains the gold standard for the treatment of essential tremor. However, it's not for everybody. People who are elderly and with significant medical comorbidities are likely better candidates for focused ultrasound than they are for deep brain stimulation. For a younger patient, and when I say younger, I'm talking 50s, maybe early 60s, DBS is better because it's adjustable. We can increase the stimulation over time. Now, there's still a limit of how high we can adjust it, but we can keep up with the tremor a little bit better as that patient ages than we can with focused ultrasound. I listed, you can read the other advantages and disadvantages here. Disadvantages of DBS, it's more invasive. There's a risk of infection. There's a higher risk of a stroke or hemorrhage, but it provides better tremor reduction for a longer period of time. What are the next steps? If you're interested in discussing whether focused ultrasound may be the best option to treat your tremor, and you've attempted medical treatment for your tremor, you can call this number to schedule an appointment and get a referral from your primary care doctor or from your neurologist. We'll review that and get you scheduled for the CT scan, the MRI, and a visit with me all on the same day at the FUS Institute. I appreciate your attention.